If you're new to ultrasound, mastering the basics is essential for becoming a proficient sonologist. Small details such as properly holding a transducer or optimizing an image can significantly impact your ability to recognize structures in an ultrasound image or guide a needle during an ultrasound-guided injection. In this lesson, I'll begin by covering basic ultrasound physics, which provides the foundation for understanding the ultrasound image and its optimization. I'll then build on this knowledge to discuss the sonographic appearance of the common musculoskeletal tissue types. Next, I'll demonstrate and review the optimal use of the transducer, including transducer selection, best practices for holding it, and key transducer movement terminology. I'll also walk you through basic ultrasound machine knobology to help you develop a systematic approach to image optimization. Following that, I'll introduce the fundamentals of Doppler imaging. Finally, I'll share my approach to image annotation. Let's get started. When I think about ultrasound physics, I start by comparing the ultrasound machine to a computer. Just as computers have become significantly more advanced over the last 10 to 15 years, so too have ultrasound machines. The technology continues to improve, and the resolution of images produced by modern ultrasound machines are much improved from those even a decade ago. The ultrasound machine sends signals to the target tissue through a transducer, which acts as both a transmitter and receiver. The process begins with the ultrasound machine generating an electrical current that is sent to the transducer. The transducer contains piezoelectric crystals, which convert electrical energy into mechanical energy in the form of sound waves. These sound waves are transmitted from the transducer into the target tissue, where they interact with various tissue types and are partially reflected back to the transducer. The transducer then converts these reflected sound waves back into electrical signals, which are processed by the ultrasound machine to create an image. Let's take a closer look at this process. Sound waves are measured in cycles per second, known as hertz. Human hearing ranges from approximately 20 to 20,000 hertz. In contrast, the sound waves produced by an ultrasound machine are typically in the range of 2 million to 20 million hertz. This incredibly high frequency does not travel well through air, but propagates readily through fluid. To enable the transmission of ultrasound signals from the transducer into the body, ultrasound gel is used to eliminate air gaps and facilitate the propagation of sound waves into the target tissues. As sound waves interact with the various tissue types, they undergo absorption, reflection, or refraction. When sound waves reflect off tissues and return to the transducer, they provide more information to the ultrasound machine, resulting in a brighter image. A brighter image is referred to as hyperechoic, indicating that more echoes are being reflected back by the tissue. Conversely, when sound waves pass through tissues, such as fluid, less information is reflected back to the transducer, producing a darker image. This is referred to as hypoechoic. Acoustic impedance, the resistance to sound waves, plays a crucial role in image formation. Tissues with high acoustic impedance, such as bone, reflect nearly all incoming sound waves and appear very bright or hyperechoic on the image. In contrast, tissues with low acoustic impedance, such as fluid, allow sound waves to pass through, resulting in a darker or hypoechoic appearance. The difference in acoustic impedance between tissue types determines the amount of reflected sound waves received by the transducer and ultimately shapes the image generated by the ultrasound machine. In this ultrasound image of a knee of fusion, both hyperechoic and hypoechoic structures are visible. The echogenic bony cortex, the hyperechoic quadriceps tendon, and the hypoechoic fluid within the suprapatellar recess are clearly identified. With this foundational understanding of basic ultrasound physics, let's examine the sonographic appearance of various musculoskeletal structures. In musculoskeletal ultrasound, image orientation is typically described in terms of long axis or short axis views rather than anatomic planes such as sagittal, coronal, and transverse, commonly used in imaging modalities such as MRI or CT. Long axis refers to positioning the ultrasound transducer parallel to the target structure, while short axis indicates that the transducer is oriented perpendicular to it. One important advantage of ultrasound is the ability to dynamically adjust the transducer to optimize the long axis or short axis imaging for a specific target structure, even as its orientation changes along its course. For example, this flexibility is particularly beneficial when imaging ankle tendons, which changes anatomic planes as they traverse from the lower leg, around the ankle, and into the foot region. The first structure to consider is bone. Bone has a very high acoustic impedance, causing all the sound waves to reflect off the bony cortex and return to the transducer. This produces a distinct, bright echogenic line representing the bone's surface. Deep to the echogenic cortex, there is no signal return, resulting in an area of shadowing where no further details are visible. The bony anatomy often serves as a roadmap for navigating the specific body part being evaluated with ultrasound. Superficial to the bone, the dark or hypoechoic stripe represents the articular cartilage. The presence of articular cartilage indicates that the bony cortex is located within the intra-articular space. Tendon appears as a hyperechoic fibrillar structure in the long axis transducer orientation due to their tightly packed, longitudinally oriented collagen fibers. In the short axis view, tendon appears as a tightly packed group of echogenic dots, often compared to the appearance of a broomstick's bristle ends. Ligament shares a similar hyperechoic fibrillar echotexture to tendons in the long axis, but are more tightly packed. In short axis, the echogenic dots of ligament also appear more densely packed compared to those of tendon. Muscle consists of groups of muscle fascicles, which appear hypoechoic, and connective tissue, which appears hyperechoic. The hyperechoic connective tissue includes the outer lining or epimysium, and multiple internal echogenic lines, which are the perimysium, which envelope the muscle fascicles. Some muscles, such as a semitendinosus, contain an internal aponeurosis that appears as an echogenic line in the muscle. The myotendinous junction is characterized by the hyperechoic tendon surrounded by hypoechoic muscle tissue. The last structure is nerve. In long axis, nerve appears as alternating hyper and hypoechoic lines, with the hyperechoic lines representing the epineurium and perineurium, the connective tissue surrounding the nerve fascicles, and the hypoechoic lines corresponding to the nerve fascicles. In short axis, nerve has a characteristic honeycomb appearance, with the fascicles appearing as hypoechoic circles surrounded by the hyperechoic connective tissue. Musculoskeletal ultrasound has many artifacts, but one of the most important is anisotropy. Anisotropy occurs when the ultrasound beam strikes a target structure at an angle other than perpendicular, causing the structure to appear artificially hypoechoic or darker on the image. This artifact can make a normal structure appear falsely pathologic. To avoid this artifact, it is important to adjust the transducer angle to maintain perpendicularity and ensure an accurate representation of the structure that is being imaged. Different tissue types have varying susceptibilities to anisotropy. Tendons are most susceptible, followed by ligaments, while bone is minimally affected by the transducer's angle of incidence. These differences in susceptibility to anisotropy can also aid in differentiating tissue types. The ultrasound image on the upper right is a short axis cineclip of the patellar tendon. The image is fairly well optimized, but as I tilt or wag the transducer back and forth, the tendon appears darker due to anisotropy. The cineclip on the bottom shows the carpal tunnel with the honeycomb echotexture of the median nerve positioned superficially and centrally, and the flexor tendons deep to it. As I again wag the transducer back and forth, the tendons readily darken due to anisotropy, while the nerve darkens to a lesser extent since nerves are less susceptible to anisotropy compared to tendons. This is one way to help differentiate the nerve from the surrounding tendons. Now that we have covered the basics of ultrasound physics and reviewed the ultrasound appearance of common musculoskeletal structures, let's turn our attention to the ultrasound transducer. This includes transducer selection, best practices for holding it during scanning, and terminology related to transducer movement. When selecting the optimal transducer, it's important to consider the depth and type of tissue being imaged. A key principle to understand is the balancing act between ultrasound resolution and tissue penetration. Higher frequencies produce sharper images but with reduced tissue penetration. Conversely, lower frequencies provide greater tissue penetration but result in lower image resolution. To balance these trade-offs, ultrasound transducers operate across a range of frequencies to accommodate different imaging needs. In addition to offering a range of frequencies, ultrasound transducers used in musculoskeletal imaging are typically either linear array or curvilinear probes. Linear array transducers have a flat surface, emitting ultrasound beams in parallel lines, which creates a rectangular field of view. They generally operate at higher frequencies, providing superior image resolution compared to curvilinear transducers. Curvilinear probes, on the other hand, emit divergent beams that produce a wider field of view. These transducers typically operate at lower frequencies, allowing a greater penetration but at the expense of image resolution. Advances in ultrasound technology now enable linear array transducers to be used for most applications in musculoskeletal ultrasound. However, curvilinear probes remain valuable for imaging deep structures, such as the piriformis muscle in the deep gluteal space, or for ultrasound-guided procedures targeting deeper structures, such as a hip joint injection. Ultrasound transducers also have a notch located on one end of the transducer. This notch will correspond to the left of the ultrasound screen. The 4 ultrasound transducers shown each have a different range of frequencies. The transducer on the left has a frequency range from 2 to 14 MHz and a relatively wide footprint. I refer to this type of transducer as a workhorse because it performs well for both superficial and deep structures, making it highly versatile. The linear array 4 to 18 transducer is ideal for superficial structures such as the wrist, hand, ankle, and foot. However, I have found it can also produce excellent images of the shoulder, elbow, and knee depending on the patient's body habitus. The next transducer is often referred to as a hockey stick probe due to its distinctive shape. It is a high-frequency transducer ideal for imaging very superficial structures, such as those in the hand or superficial nerves. Finally, the transducer on the far right is a curvilinear transducer with the typical lower frequencies. How we hold the transducer during scanning is very important. A common adage is that ultrasound imaging should be a contact sport. This phrase emphasizes the importance of using your hand to stabilize the transducer by making contact with the patient, rather than relying solely on the transducer as the contact point. There may be some variation in how experienced sonologists hold a transducer, but the common denominator is that the hand serves as the primary stabilizer and not the ultrasound transducer. This principle is not only important for diagnostic imaging, but also for ultrasound-guided injections or procedures. Using the hand to provide a stable base for the transducer minimizes movement, which is key for tracking a needle or other instrument accurately. Finally, it's important to become familiar with the terminology associated with transducer manipulation. Simply moving the transducer across the patient's skin without changing its angle of incidence is called sliding the probe. Adjusting the transducer angle in the long axis, tilting it away from 90 degrees, typically with one end fixed, is called the heel-toe maneuver. When the transducer is lifted slightly off the skin while maintaining contact with the help of ultrasound gel, it is termed a standoff technique. Angling the transducer in its short axis, away from 90 degrees, is known as tilting or wagging the probe. The next topic is image optimization, a very important skill in ultrasound imaging. Many ultrasound machines are equipped with advanced settings and tools designed to enhance image quality, often organized into presets. These presets are pre-configured settings tailored to specific anatomic regions and transducer types. For example, a wrist or hand preset typically uses a high-frequency transducer optimized for very superficial structures. In contrast, a shoulder preset often utilizes a transducer with a broader frequency range to accommodate both superficial and deeper targets. While presets are very helpful, it is still important to develop proficiency in image optimization. I will present a 4-step approach that will be sufficient in most situations. The first step is transducer selection, which I have already touched upon. Once the optimal transducer is selected, the next step is to adjust the depth. The depth setting should aim to create an appropriate field of view that optimizes the resolution of the target structure. The two images on the right are of the patellar tendon. The one on the left has an optimal depth or field of view, since it primarily focuses on the tendon with very good resolution, allowing for clear identification of any pathology. It also provides a view of the patella in portions of Hoffa's fat pad. In contrast, the depth in the image on the right is set too deep, resulting in an unnecessarily large field of view and loss of tendon resolution. In the second example, the ultrasound images show a long axis view of the gluteus minimus tendon. The image on the left focuses on the tendon's attachment onto the anterior facet of the greater trochanter. However, in my experience, a larger field of view allows for a visualization of the full muscle tendon unit, which helps to optimize the transducer's orientation in the long axis position. In addition, early pathology often begins at the myotendinous junction near the distal edge of the anterior facet, which is easier to detect with a greater field of view. The next step in image optimization is adjusting the focal zone. Some ultrasound machines will automatically set the focal zone based on depth, but most allow manual adjustment. For linear array transducers, the ultrasound beams penetrate tissues in an hourglass configuration. At a certain distance from the transducer, the beams narrow to a focal point, providing the highest image resolution. Beyond this point, the beams begin to diverge. The focal zone can be adjusted in both depth and width to optimize imaging. Ideally, the focal zone should be positioned at or just below the target structure to achieve the best resolution. The ultrasound images show pre-injection views for a posterior glenohumeral joint injection, where the target tissue is the joint space deep to the posterior labrum. In the top image, the focal zone is correctly set at the level of the target, optimizing resolution. In contrast, the image on the lower left has a focal zone set too shallow, reducing the resolution of the target area, while the image on the lower right has a focal zone set too deep, also compromising resolution. In another example of a long axis view of the patellar tendon, the top image has the focal zone correctly positioned just below the tendon. The lower image has the focal zone set too deep, leading to decreased resolution of the tendon. The last step in basic image optimization is adjusting the gain, which controls the brightness and contrast of the image. An ultrasound image consists of many shades of gray, so it's important to optimize the contrast between different tissue types. Returning to the patellar tendon example, the image at the top has the gain set to enhance the contrast between the tendon and surrounding tissues. I've artificially increased and decreased the gain in the lower images to demonstrate how contrast is compromised when the gain is adjusted improperly. Sometimes, when the target tissue is either superficial or deep, adjusting the gain can cause other structures within the image to become too bright or dark. Time gain compensation allows selective adjustment of the brightness at different depths. The three images show the gluteus minimus tendon. The image on the left effectively optimizes the tendon's insertion onto the anterior facet of the greater trochanter. However, if I wanted to improve visualization of the deeper anterior hip joint, turning up the gain would also brighten the more superficial structures, compromising their contrast, as shown in the middle image. Using time gain compensation, I can increase the gain at deeper levels without affecting the brightness of the superficial structures, thus better optimizing the image as shown in the image on the right. Doppler imaging is an important component of musculoskeletal ultrasound. It works by detecting the movement of red blood cells within blood vessels, which causes a shift in the frequency of the ultrasound waves, a phenomenon known as the Doppler effect. In musculoskeletal ultrasound, Doppler imaging is used to visualize vasculature, a potentially important part of diagnostic examinations. Additionally, identifying blood vessels is essential when planning ultrasound-guided injections or procedures to avoid vascular injury. The presence of vasculature in soft tissue often indicates inflammation, as seen in conditions like synovitis or infection. Finally, the identification of neovascularization within tendons is a significant finding in tendinopathy. Most ultrasound machines are equipped with both power Doppler and color Doppler capabilities. Traditionally, power Doppler is more sensitive to low-velocity blood flow, such as seen in tendinosis. In contrast, color Doppler, while less sensitive to flow, provides more detailed information about flow characteristics, including velocity and direction. However, the sensitivity of color Doppler in modern ultrasound machines is more than adequate for musculoskeletal applications. Newer technologies, such as microvascular Doppler, offer improved resolution for detecting subtle vascular signals, but are beyond the scope of this discussion. For color Doppler, ultrasound machines are typically configured so that blood flow towards the transducer appears red, while flow away from the transducer appears blue. In this example, the ultrasound image is a cine clip of the radial artery. Initially, the artery appears red because the transducer is angled slightly to direct blood flow towards the probe. As I slowly tilt the probe, changing the angle so that the blood flow moves away from the transducer, the vessel turns blue. When I return the probe to its original angle, directing flow back towards the transducer, the vessel appears red again. When using Doppler imaging, several techniques can improve accuracy and image quality. First, it is important to reduce transducer pressure to avoid compressing vasculature, which can obscure blood flow signals. Using a generous amount of ultrasound gel helps to minimize transducer pressure while maintaining proper acoustic contact. In both images, gel is applied between the skin and transducer to reduce compression of the transducer. Additionally, the Doppler sample box should be adjusted to focus on the specific region of interest, improving the detection of vascular signals while reducing extraneous noise signal. Proper Doppler gain adjustment is also important when imaging vessels. The gain should be set high enough to fill the vessel with Doppler signal while minimizing background noise. In the first of 2 cine clips of the radial artery, I adjust the sample box to appropriately isolate both the radial artery and cephalic vein. In the second cine clip, I gradually increase the gain to fill the vessels with Doppler signal, then raise it further to demonstrate the appearance of artifacts. Finally, I decrease the gain to confine the Doppler signal within the vessels. Excessive gain can result in unwanted background noise, so careful adjustment is important for accurate imaging. When assessing for Doppler activity in soft tissues, such as joint synovium or subcutaneous tissue, the gain should be increased until background noise becomes visible and then reduced to the point where only minimal artifact remains. This technique ensures accurate visualization of subtle vascular activity. I demonstrate this technique in the dorsal recess of the second metacarpophalangeal joint. In the first cine clip, I again optimize the sample box. In the next video, I increase the gain until artifact appears, then gradually decrease it to achieve minimal artifact signal. Finally, when imaging tendons, the tendon should be slightly tensioned during grayscale imaging, but relaxed during Doppler imaging to optimize blood flow detection. For example, when evaluating the common extensor tendon of the elbow, the wrist should be supported to avoid over-tensioning the tendon. Similarly, for the Achilles tendon, a slight tension during grayscale imaging enhances structural detail, while relaxation during Doppler imaging improves vascular signal detection. The final topic to discuss is image annotation. Most mid to high-end ultrasound machines offer annotation presets to streamline labeling of images. In my opinion, images should be clearly labeled so that anyone familiar with musculoskeletal ultrasound can easily interpret them. This typically includes information regarding the side, such as right or left, the region being evaluated, and the orientation of the image, such as short or long axis. Occasionally, I'll also annotate specific structures on the image to further clarify the anatomy. Other common annotations include words such as compare, region of interest or ROI, dynamic, the anatomic direction of a cine clip such as proximal to distal, injection or aspiration, and so forth. In this first example, the initial image in my wrist protocol is a long axis view of the dorsal synovial recesses. The annotation includes the side, location, and transducer plane. I've also labeled the capitate bone to clarify the bony anatomy and exact position of the transducer. This next image is a short axis view of the wrist evaluating the dorsal scapholunate interosseous ligament, where I labeled the scaphoid bone to eliminate any potential confusion. This next example involves a patient referred for an ultrasound-guided flexor tendon sheath injection. In my initial images, I labeled the side, finger, and structure of interest. Additionally, I performed a short axis proximal to distal cine clip and a long axis dynamic flexion and extension video, labeling the image accordingly. For the injection, I also labeled the cine clip appropriately. If a cine clip is captured during the injection, then I may not include post-injection images depending on the circumstances. In another case involving a lateral elbow evaluation, I obtained and labeled a contralateral comparison view. In summary, this lesson has covered the basics of ultrasound physics, the echotexture of various musculoskeletal structures, transducer fundamentals, and image optimization techniques, including Doppler imaging. I also briefly discussed image annotation. These foundational principles provide you with the practical knowledge and techniques needed to optimize your musculoskeletal ultrasound examinations effectively.